Congenital hip dislocation or developmental dysplasia of the hip in kids. Hip is a ball and socket joint, consists of the acetabulum and the femoral head. The surface anatomy of the acetabulum is characterized by its three major components: ilium, ischium, and pubis. At skeletal maturity, these three bones fuse into one at the central triradiate cartilage. The outer articular margin of the acetabulum is continuous with the labrum. The fibrocartilaginous labrum, together with the transverse acetabular ligament, forms a complete ring around the acetabulum, which is largely fully formed and developed at birth. The capsule of the hip joint attaches to the edge of the acetabulum proximally. Distally, it attaches to the intertrochanteric line anteriorly and the femoral neck posteriorly. Acetabulum and femoral head development are intimately related. The normal concavity of the acetabulum develops in response to the presence of a concentric femoral head. Developmental dysplasia of the hip affects the immature hip of the infant and consists in abnormal development of the hip joint, resulting in incongruent relationship of the femoral head to the acetabulum. In simpler terms, developmental dysplasia of the hip is a condition where the ball part of your thigh bone doesn't sit in the socket properly, leading to it being shallow so that the hip socket doesn't fully cover the femoral head. This makes the joint less stable and causes dislocation. In addition, changes occurs in shape, size and orientation in both femoral head and acetabulum, and if left untreated can lead to issues walking, extremely painful hips, and osteoarthritis by young adulthood. The reported incidence of developmental dysplasia of the hip varies between 1.5 and 20 per 1,000 births, with the majority of abnormal hips resolving spontaneously within 2 to 8 weeks. Developmental dysplasia of the hip affects girls more than boys, and it is more common among babies born into families with a history of developmental dysplasia of the hip. The left hip is affected 3 times more often than the right. It can also affect both hips. The exact causes of DDH are not always known. Hip instability might appear after birth in babies who were in the breech position for an extended period of time before delivery. Any physical limitation, for example oligohydramnios or twins, in utero can contribute to DDH. 6 out of 10 cases of hip dysplasia occur in firstborn children. It may be because a mother's womb is tighter during her first pregnancy, which can sometimes restrict fetal movement. Improper swaddling may also contribute to DDH when an infant's legs are swaddled in a straight, close position. DDH can occur in otherwise healthy children, or it can be associated with specific conditions or syndromes including neuromuscular diseases, such as cerebral palsy, hyperlaxity, commonly seen in Ehlers-Danlos and Marfan syndromes, skeletal dysplasia, a grouping of disorders that affect how children's bones grow. It can be hard to detect hip dysplasia because it is a silent condition. It won't cause your little one to cry in pain and doesn't typically prevent babies from learning to walk. Hip dysplasia in babies is often discovered at or soon after birth during routine wellness exams. The severity may vary from mere dysplasia where the acetabular cavity is shallow but the femoral head is within it, or subluxation, the femoral head is dislocated from its normal anatomical position, but still maintains some contact with the acetabular cavity, or dislocation, where there is no contact between the femoral head and the acetabular cavity. If the child's symptoms are mild, it can go unnoticed during infancy and childhood. In some cases, it might worsen, causing hip pain later in life. When this occurs, we refer to the condition as adolescent hip dysplasia. There is a rare condition called teratologic hip dislocation. Occurs in 1 to 2% of perinatal hip dislocations. It is associated with arthrogryposis, chromosomal abnormalities, and others. Teratological dislocation is produced during the first months of intrauterine life. At birth, the joint reduction will be impossible. There are few things that you as a parent may also notice at home that could indicate hip dysplasia. If you notice any of the following, be sure to bring it up with your pediatrician to check out. You may notice that when your baby is laying on their tummy that one buttock crease is lower than the other. Asymmetrical buttock creases can suggest hip dysplasia in some cases, but can also be a normal finding. When changing your baby's diaper or moving their legs, you may feel a click in their hip. This can also be a normal finding, but can also be an indicator of hip dysplasia. You might have difficulty putting diapers on them because their hips have a limited range of motion and can't fully spread. You may notice that one leg seems longer than the other. This can be an indication of hip dysplasia. After learning to walk, a waddling type gait and an exaggerated swayback becomes noticeable. Talk with your pediatrician if you have concerns. Physical examination. The ideal situation is to perform the examination in the maternity ward, or within the first few days of life. The examination should clearly include taking the history, to assess the risk factors and antecedents, as mentioned earlier, in order to draw up the diagnosis. Signs and symptoms vary by age group. Among newborns and infants younger than 3 months, the diagnosis of DDH is eminently clinical and is made using the Ortolani and Barlow maneuvers. Barlow's sign is a maneuver to provoke dislocation of an unstable hip. With the child in dorsal decubitus, the thigh is kept at right angles to the trunk, in a position of adduction. In Barlow's test, the upper part of the femur is kept between the index and middle fingers, above the greater trochanter, and the thumb is kept in the inguinal region. Force is exerted by the child's knee vertically to the hip, in an effort to dislocate the femoral head from inside the acetabulum. If the joint is dislocated, a palpable clunk is noticed as the head slides out of its place. Ortolani's sign is exactly the opposite. It is a test for dislocated hip reduction. When newborn with a dislocated hip joint is examined, the femoral head is reduced into the acetabulum through the maneuver. The maneuver is performed with the child in dorsal decubitus with the hips and knees in the position of 90 degrees flexion, and the thighs in adduction with slight internal rotation. In making a hip abduction movement, possibly accompanied by slight external rotation of the thighs, a palpable clunk is noticed as the head slides into its place. Sometimes there may even be an audible sign of this protrusion. Such cases are thus said to present a positive Ortolani sign. One hip is examined at a time, with the other hip well stabilized, in a position of slight abduction. Between 3 and 6 months of age, hip reduction in conscious children may become difficult. For this reason, it is uncommon to find children with a positive Ortolani sign in this age group. The examiner should also bear in mind that if children present cracking noises at the time of undergoing the physical examination, this may not be due to an unstable or dislocated hip. Another later sign is Galeazzi's sign. With the child lying down with flexed knees, they will not be at the same height. This denotes a difference in length between the lower limbs. This sign will clearly be more evident in unilateral cases. From 3 months to 1 year, we find limitations in hip abduction and leg length discrepancy. older than greater than 1 year child. We find pelvic obliquity, lumbar lordosis in response to hip contractures resulting from bilateral dislocations in a child of walking age, Trendelenburg gait that results from abductor muscles insufficiency in the affected side. As I have mentioned before, since DDH is a common congenital abnormality, all newborns must be screened by physical examination. For children with apparent risk factors of developmental dysplasia of the hip with or without clinical features of DDH, often need additional testing to confirm it, including ultrasound. This test is recommended for infants 4 months and younger, because the hip is still predominantly cartilage and unable to be seen clearly on other scans. Ultrasound is necessary to make the diagnosis if the physical exam is positive or when hip dysplasia is suspected. We recommend an ultrasound study at 6 weeks in patients who are considered high risk, such as family history or breech presentation despite normal examination. It is also used for monitoring of reduction during Pavlik harness treatment. It allows view of bony acetabular anatomy, femoral head, labrum, ligamentum trees, and hip capsule. There are angles that are measured during the examination. The one that is used the most to help guide treatment is the alpha angle. It is the angle created by lines along the bony acetabulum and the ilium. This angle is considered normal if it is more than 60 degrees. Dysplasia is present when the alpha angle is less than 60 degrees. The other angle is beta angle, which is the angle created by lines along the labrum, and the ilium normal is less than 55 degrees. During the ultrasound examination, the hip is also examined for stability in the same manner as the Barlow test. But the ultrasound is used to see if the hip is unstable instead of relying on the feel of the doctor. Radiography of the pelvis starts to be used for confirmation of DDH later on, after children have reached the age of 4 months, since the femoral head does not become ossified until the age of 4 to 6 months. In radiographic evaluations for diagnosing DDH during the first months of life, indirect measurements and signs have to be used, such as Hilgenrainer's horizontal line, Perkins's vertical line, Shenton's line. Hilgenrainer's line is a horizontal line through the right and left triradiate cartilage. In normal kid, the femoral head ossification should be inferior to this line. Perkins' line is the line perpendicular to Hilgenrainer's line through a point at the lateral margin of the acetabulum. In normal kid, femoral head ossification should be medial to this line. Delayed ossification of the femoral head is seen in cases of congenital dislocation. Shenton line is an imaginary curved line drawn along the inferior border of the superior pubic ramus and along the inferomedial border of the neck of femur. This line should be continuous and smooth. Interruption of the Shenton line can indicate developmental dysplasia of the hip. Acetabular index. The acetabular index, also called acetabular roof angle. It is a radiographic measurement of femoral head bony coverage by the acetabulum. It is the angle formed by Hilgenrainer's line and a line from a point on the lateral triradiate cartilage to a point on lateral margin of acetabulum. Should be less than 25 degrees in patients older than 6 months. And at 2 years, 20 degrees. An angle of 30 degrees or more is considered to be greater than the normal. Once a diagnosis of hip instability or dislocation has been established, treatment will be started with the aim of reducing the femoral head into the acetabular cavity so the latter is stimulated to grow normally. Classically, The treatment possibilities are divided according to the different age groups at the time of the diagnosis. Treatment for newborns up to 6 months of age. Treatment for babies younger than 6 months old is usually with an orthosis braces. Today, the orthosis most commonly used is Pavlik's harness. This orthosis provides simultaneous flexion and abduction of the hip joint through straps that join together relatively easily. Anterior straps flex the hips to 90 to 100 degrees flexion and prevent extension. Posterior straps prevent adduction of the hips. The treatment is based on the concept that if the reduced hip is kept positioned in flexion and slight abduction, the stimulus needed for normal development of the joint will be provided. The treatment with Pavlik requires normal muscle function for successful outcomes, so that it's contraindicated in teratologic hip dislocations and patients with spina bifida or spasticity. At first you should keep your baby in the harness all the time. After about 6 weeks, you will be able to take your baby out of the harness during the day. The baby will need to continue wearing the harness at night for about 6 more weeks. The harness is adjustable, so it can change as your baby grows. The child has to be examined frequently in order to evaluate whether the device has been applied correctly, usually once a week. It is very important to have your baby's legs positioned correctly. Do not try to adjust the harness yourself. The baby will also need regular ultrasounds every 4 to 6 weeks to follow development of the hip joint. 90% of the dislocated hips among children aged under 6 months could be successfully reduced and thereafter presented normal development through using this orthosis. If concentric reduction is not achieved over the first 2 to 3 weeks of use of the harness, this approach is abandoned to prevent Pavlik disease. Then the choice is to perform closed reduction and immobilization in a plaster cast brace. Complications specific to this treatment: avascular necrosis, AVN, seen with extreme abduction, greater than 60 degrees. This complication can be prevented via placement of abduction within safe zone. The safe zone or safe arc of motion is the range of abduction in which the hip maintains stability. It is calculated by assessing the maximum unforced abduction of the hip. Then, the hip is brought into adduction, and the degree of abduction with the hip dislocated is recorded. We take about 10 degrees from each end, resulting in a safe zone. Hips with a narrow zone of safety, less than 30 degrees, are less likely to be stable. A popular method of increasing the safe zone is to perform an abduction tenotomy. The abductor tenotomy theoretically would increase the maximum and unforced abduction and increase the safe zone. Transient femoral nerve palsy, seen with hip hyperflexion. Pavlik disease. It is an erosion of the pelvis superior to the acetabulum and prevention of the development of the posterior wall of it, due to prolonged positioning of dislocated hip in flexion and abduction. It is important to discontinue the harness if the hip is not reduced by 3 to 4 weeks. Treatment between 6 months of age and walking age. Within this age range, most patients with DDH can be treated by means of closed reduction and immobilization in a plaster cast brace from the pelvis to the foot called spica cast under general anesthesia. Apply spica cast to immobilize in 100 degrees of hip flexion and 45 degrees of abduction with neutral rotation for 3 months. You have to change cast at 6 weeks. Avoid wide abduction because extreme abduction greater than 60 degrees is associated with avascular necrosis of the femoral head, AVN. So we can prevent the AVN via placement of abduction within safe zone that we have already explained. During the operation, percutaneous tenotomy of the hip adductor muscles may be necessary if the patient has an unstable safe zone, if excessive abduction is required to maintain the reduction. Confirm reduction with CT scan in spica cast with selective cuts to minimize radiation to the child. After the period of immobilization in the plaster cast brace, which will range from 2 to 3 months, the patient will progress to using an abduction orthosis for a further 2 to 3 months. When reduction through closed maneuvers cannot be achieved, open reduction is indicated. Treatment after reaching walking age. This requirement ought not to exist, since the ideal is to make the diagnosis well before this age. Nevertheless, for some children, there may be either diagnostic failure or failure of the consequent early treatment. Surgery is necessary with a procedure called open reduction for children older than 1.5 or if a closed reduction doesn't work. During surgery, the possible anatomic blocks to reduction will be removed, such as iliopsoas contracture, capsular constriction, inverted labrum, pulvinar, or hypertrophied ligamentum teres. Perform adductor tenotomy if the patient has an unstable safe zone, if excessive abduction is required to maintain the reduction. For this age group, along with the need to operations to perform complementary osteotomy in the acetabular region to improve the femoral head coverage, such as steel osteotomy, Degas osteotomy, Salter osteotomy, Pemberton osteotomy, among other types. After the age of 3 years, the femoral bone shortening to enable the joint reduction has to be taken into consideration. It facilitates reduction and decreases the risk of AVN by relieving the tension produced by the reduction of a previously dislocated hip. Structural defect in the acetabulum is a constant finding in developmental hip dysplasia. It can occasionally be directly superior anterior, superior, or posterior superior. And surgical correction of dysplasia should include correction of this defect to improve the femoral head coverage. The standard pelvic radiographs do not differentiate anterior, superior or posterior deficiency. A 3D CT greatly helps determine an individual hip's exact morphology and plan for an osteotomy specifically to correct the defect. We recommended routine pelvic osteotomy at the time of open reduction for all patients over the age of 18 months. The pelvic osteotomies can be broadly grouped into 3 types. Redirectional osteotomies such as Salter osteotomy, triple osteotomy, steel, and periacetabular osteotomy, GANS. Reshaping osteotomies such as Pemberton osteotomy and Degas osteotomy. Salvage procedures such as Chiari osteotomy and shelf procedure. The choice of pelvic osteotomy depends on the age of a child, the type of dysplasia and the status of the triradiate cartilage. In general, if a concentric reduction is not possible by any described methods, salvage procedures are opted. Salter osteotomy. Salter osteotomy is performed in younger patients between 18 months and 8 years of age, typically with open triradiate cartilage. The primary indication for an Salter osteotomy is an anterolateral acetabular deficiency in an otherwise concentrically reduced hip. The Salter osteotomy is a transverse iliac cut from just above the acetabulum, extending to the sciatic notch. The distal acetabular fragment is rotated laterally and provided anterior and/or lateral coverage of the femoral head. A triangular wedge of bone is cut from the iliac crest and placed into the osteotomy site and fixed with 2 or 3 threaded K-wires. Triple osteotomy, steel. The primary indications are in older children and adolescents with open triradiate cartilage because their symphysis pubis does not rotate well. The 3 separate osteotomies are performed on the lower portion of the ischium, on the ilium above the acetabulum, and on the superior pubic ramus. Then the acetabulum is reoriented by rotating the fragment created by these osteotomies. It is an unstable osteotomy requiring rigid fixation and immobilization. The drawback of steel osteotomy is it violating the posterior column and creating pelvic discontinuity. It leads to pelvic asymmetry and affects the birth canal, negating the possibility of a normal vaginal delivery. Pemberton osteotomy. Pemberton osteotomy is recommended for moderate to severe hip dysplasia in children under 6 years old with open triradiate cartilage. In this, a bicortical iliac osteotomy is done, which starts just above the anterior inferior iliac spine, and proceeds posteriorly to end at the level of the ilioischial limb of the triradiate cartilage. The osteotomy is curvilinear, parallel to and approximately 1 cm above the joint capsule. The correction is maintained by a wedge of bone taken from the iliac crest. Periacetabular osteotomy, GANS. The primary indication of GANS osteotomy is to improve the congruency and coverage of hip with acetabular dysplasia in patients with closed triradiate cartilage. GANS osteotomy is a complete reorientation osteotomy with bone cuts made close to the acetabulum that can allow for the maximum correction of lateral and anterior coverage. These include an incomplete osteotomy of the ischium, a complete osteotomy of the pubis, and a biplanar osteotomy of the ilium in which the continuity of the posterior column of the acetabulum is maintained, which permits early return to mobilization and W height bearing. Additional advantage includes preserving the shape of the pelvis, which permit normal vaginal delivery. The major disadvantage is the technical difficulty. Dega osteotomy. Dega osteotomy is favored in neuromuscular dislocations such as cerebral palsy, in patients with posterior acetabular deficiency, and for severe cases. The osteotomy begins anteriorly on the interspinous ridge between the anterior superior and anterior inferior iliac spine. The orientation of the osteotomy is curvilinear when viewed from the lateral cortex, starting just above the anterior inferior iliac spine, curving gently cephalad and posteriorly to end approximately 1 to 1.5 centimeters in front of the sciatic notch. The osteotomy is bicortical anteriorly, and a variable amount of posteromedial cortex of the inner table of the pelvis in front of the sciatic notch is left intact. Bone graft is shaped according to the gap at the osteotomy site. The cut does not enter the sciatic notch and is therefore stable and does not need internal fixation. It improves anterior, central, or posterior coverage but reduces the acetabular volume. Chiari osteotomy. It is a salvage procedure which aims mainly to achieve lateral coverage of femoral head in adolescents with acetabular dysplasia if a concentric reduction is not possible. The level of pelvic osteotomy is very important and crucial. It should be less than 5 mm from the joint space and directed with a cephalic inclination of 10 degrees toward the sacroiliac joint. It is a single paracapsular osteotomy through the iliac bone of the pelvis with medialization of the acetabulum and hip joint to improve posterior and lateral coverage. The ilium forms a shelf over the dysplastic, subluxated hip. Shelf procedure. It is a salvage procedure performed in patients greater than 8 years old with acetabular dysplasia if a concentric reduction is not possible. In this procedure, iliac crest bone grafts are placed into the lateral portion of the ilium at the acetabular margin. It improves support of the femoral head by widening the roof of the acetabulum over the joint capsule and thus prevents subluxation. The child will be put into a hip spica cast in functional position of 30 degrees of flexion, 30 degrees of abduction and 30 degrees of internal rotation after surgery for 3 months. Often a child will then need a hip abduction brace to finish the healing process.